First part is going to talk about healthcare as a complex adaptive system and really not talk about empowerment at all. This piece grew out of some work I did for the Cancer Society in the late 90s. The executive team and the board of directors asked me to look at how they spent their money and where was the best place to put the money in the system to have the most impact on the disease. This raised the question of, well, what is the system? And that's where this line of reasoning actually came from. One thing is it's not an engineered system like an airplane or a factory or a power plant. It's a system that emerged over time. It's a socio-technical system and has a lot of characteristics that more engineered systems don't have. So we're going to summarize that in one extremely intense slide, which you'll get to in a second, and then illustrate it. So this is what we mean by complex adaptive systems. I realize this may present reading problems from the back row. The red is all that counts. They're nonlinear dynamic. Their responses are sometimes disproportionate to their inputs. They're composed of independent agents. Those agents have goals and behaviors that are likely to conflict, as Les just said, between the payer, the provider, and the patient. They're intelligent and learn. And will adapt their behaviors. They're self-organizing. I've often thought that healthcare is just a federation of millions of entrepreneurs with nobody in charge. And there's no single point of control. There's no one place to go and talk and get a change made. Okay? And as you'll see later, as a result, you have more influence over a system like this rather than control. You've got an empowerment conference today, Les. Sorry. It's okay. Does it just disappear on its own?
Yeah, if you just click on it, it should go away.
Okay. Hey, I mean, the good news is you're in the right place. So the rest of this the first part of the talk, is to elaborate on this. So when we were doing the work for the Cancer Society, the question was, well, who do you try to influence in the system? And as you can see here, between risk management, prevention, detection, and treatment, there are an enormous number of stakeholders in this system. And the question of where you invest your money in the case for ACS was much more complicated than was originally thought. So for example, you could put all your money in medical research, and that was a lot of pressure from the donors. Put all the money in medical research, even though it was small relative to what NIH was spending. Okay. The difficulty is you don't actually get the impact on the patient unless you do all these other things, which NIH wouldn't do, at least at that time. Okay? The public has to be aware of a new screening technique. The public has to be ready to do it. They have to be educated. The physician has to be aware and educated. There has to be consumer advocacy so the costs are covered. So you need all these things to be in place to actually impact the disease. And if you just pour all your money into medical research and don't do any of these other things, the chances are you'll get great journal articles, but no impact on the patients, or little impact on the patients. Now, when I was doing this, I realized I made an assumption that perhaps isn't fully warranted, and that was that there were physicians. I just assumed they were there. Then I subsequently participated in a meeting that was about how do we end up getting physicians to go through accredited programs and licensed. And basically, as the people were talking, like in a meeting like this, I was writing down what I heard. And these are some of the various players on getting a physician. And many of these, there's probably more, but this is just what was mentioned in the meeting. Many of these are different in each state. Okay? So we really have a very complicated system here with a lot of players playing very different roles. Some of the people in the room that were talking about these other things did not mention health outcomes at all. They were mentioning rules and regulations and things like that. So it's very complicated in terms of dealing with this whole system. So the NAE had an IOM had a learning healthcare system workshop as part, engineering the learning healthcare system workshop as part of the evidence-based medicine roundtable. And I chaired that with Jerry Grossman. And actually, by the time we had the workshop, Jerry Grossman had passed away, and Dennis Cortese co-chaired it with me. And my job on the second day was to summarize everything said on the first day. And it became very clear, and this really relates to the micro, meso, macro level. It was very clear people were talking about different things. Some people are talking about clinical practices and people interacting with patients. Other people are talking about processes of how care is delivered. Other people are talking about organizations and businesses and how those businesses provide part of the processes. And other people were talking about the overall ecosystem and what do we value. For example, if our healthcare system does not value human productivity at all, right? I mean, if the idea of a healthy, productive population is no value, it's just cost, well, obviously we will dramatically lower what we'll invest. But in fact, we of course want more than that. And so what gets in the equation precipitates down what gets paid for, what gets valued, et cetera. And we're going to show you some results of a simulation of this structure. This turns out, Dennis and I, Jerry and I were going to do it, but Dennis and I decided to put this book together that Les has a chapter in that has lots of people you know, Don Berwick, Bill Stead, et cetera. And this was the first figure in the book. In a minute, I'm going to show you the last figure in the book. It's 500 pages. Several people have told me it actually is very good to read at night when you're tired. But it's a lot of luminaries that you know. And so that's how the book started out. Now, what do you do in this complex adaptive system? We tend to think that we can do this, that we can manage it as a traditional system. We'll manage it, we'll tell people what to do, we'll monitor their activities, we'll focus on efficiency. Everything is contractual as a hierarchy, and we will design the organization. And we can't do those things. We try, but it's the wrong set of things to do. What we need in a complex adaptive system is we need leadership who can negotiate the right incentives and inhibitions being regulations, things you can't do. Okay? Incentives and regulations that will likely lead to the right outcomes. Typically in a complex adaptive system, you can't manage the activities because you can't see them. There's all these different organizations operating independently, trying to do their part. Okay? You're not so concerned with efficiency as you are with agility. The organization to be a change, adopt new information, bring in new evidence, learn, is more important than efficiency. Personal commitments are often more important than contractual because you can't have a contract with everybody. Okay? The hierarchy is what matters, how things flow across the different players, not who's in charge, because nobody is in charge, and it self-organizes. So anything that you do, when I get to the patient empowerment discussion, all the other players will self-organize around how we decide to empower patients, right? Because that's the way a complex adaptive system works. Now, where are we headed? This is the last figure in the 500-page book. And we spent a lot of time on this figure. Where are we going? And we use it as an analog, not as a model that we should aspire to, but as an analog, the retail industry. As you know, there were many times it was just mom and pop stores when at least people my age were kids. Okay? And then it went to integrated retail systems, Walmart, Target, et cetera. At this point, Procter & Gamble was in charge. We had to buy whatever they do. At this point, Walmart's in charge. They tell Procter & Gamble what to produce and what they'll pay for it and when they should deliver it. But with the internet, everything has really become consumer-directed retail. The consumer knows everything. I bought several cars on Edmunds.com. You go in, actually the dealer gives me a lower price than I thought was imaginable. And I said, I'm really surprised you give me this price. He said, well, you know more than I do. He said, you know everything. He said, I got one shot to get you to buy this car. So I'm going to give you my best shot right up front. That's a really total change in car buying. Now what's going to happen over here? We've got these fragmented specialty practices. We're going to go, I think, over the next 10 years to integrated health systems, not in the sense that they'll necessarily be all part of one corporation, okay? But we will have increasingly small practices will federate and there'll be a common back office provided. The individual one or two physician organization will not be able to survive. They'll be able to afford without federating. And so there's lots of examples of that. But inconsistent with what we talked about in this meeting, what you presented last night and what Les talked about, we are going to get here, I think, where the consumer has all the information they need and the tools to make the right kind of decisions. I think they may also have, and I'll come back to this, health coaches that help them. It won't be just all automated on the internet. But those health coaches will probably not be physicians or even nurses. But we'll come back to that. I just made these names up. You might wonder where they are. They don't exist. But this is the idea of where the industry's headed, and it's perfectly aligned with patient empowerment. Okay, so now let's talk about how do we empower patients in a complex adaptive system. And I'm going to start with an example we've worked on for Emory. Okay. Here's a dashboard that we created for Emory so they can simulate their employer-based prevention and wellness program at all 4 levels. At the ecosystem level, where we worry about inflation, et cetera. At the level of the provider organization, which is part of Emory. And at the other 2 levels you'll see in a second. So we can actually do what ifs. And what you're going to find out with the results here is that if they take 700 people, they put these cohorts through, they have enormous impact on diabetes and heart disease. Okay. Now the question is, do we do this for all 40,000 people that would be available to this? Scaling that up would be a disaster, you'll see. But there is a way to scale it up. And we're able to explore that computationally and convince them that they need to radically reorganize how they're delivering it. Although what they're delivering is very good. And I'll come to that in a second. At the lowest level of the simulation, this is the 700 people. They're color-coded for what they're doing right now. Actually, there's more people in there because we're projecting growth over time. One thing surprised me with this diagram. It's running in real time, and they can watch it as the colors change and people do things. Some of the clinicians commented they never had a way to look at their whole cohort at once before. And the idea that the orange people are talking to their health coach, the gray people are off doing other things in life, the blue people have just come for the first time. That was amazing to them. I didn't realize they would perceive the value of that. Now, the prevention and wellness program they're delivering is this. This was a bit of a shock to the clinicians. But there's an assessment and goal setting process, an education facilitation process, and a maintenance process. One interesting thing about this is they never see a clinician except when they have blood drawn. Never a doctor, never a nurse. Okay? The actors in this are called health partners. They're really health coaches. Each one of them has 100 clients, participants. The one I've interacted with most, her other job is she's an aerobics instructor. They go through a 16-hour assessment, 2 full-day assessment. They then get a 100-page report of basically everything you possibly want to know about yourself. And the coach or partner sits down with them and says, okay, given this, what would you like your goals in life to be relative to your health? And they come up with the goals. And then the partner, this is all via cell phone and email, the partner interacts with them every week about how are things going. And did you get to go to the gym like you said you were going to go? Did you go on that hike, et cetera, et cetera? My sense is that social interaction with that partner has an enormous impact on people. And then we have a maintenance mode where we don't keep on doing several $1,000 assessments every 6 months for 20 or 30 years. You have to have people switch into a maintenance mode where we just do basic body measurements once every 6 months. I realize this is kind of hard to understand, but it's a discrete event flow model of what goes on in their program.
So, an executive thing? It's expensive. You said $20,000.
It's $2,500 a person per year. And then what they got is a $10 million gift to do it. And then what happened, and the next slides will make this really clear, they spent the money. So then they went to HR and they said, we're having this impact on our employees, why don't you pay? And HR said, well, what value do you provide? And so we got involved and said, well, we'll show you. We'll create an economic model to project the value provided.
Maybe just on that multiphasic screening, this sounds a lot like, and that hasn't usually proven to be very useful for the long run. So
Yeah, well, you'll see our results. We've got all the clinical data from several years of this now.
Real quick question. Has the partner also been through the process as a client?
I know they're extensively trained. I don't know whether they actually enroll in the process.
That might be helpful.
Yeah, they are extensively trained, but I don't.
They've had the experience.
Yeah.
And they could be communicating.
Yeah.
Just
Yeah.
a thought.
Yeah, and that's an interesting idea. I might mention one thing up here. You see there's 2 sliders here for diabetic risk and heart disease risk. This slider here stratifies people into high and low risk. This one is what their risk reduction is per year, depending on where you stratify. And so using models Peter Wilson developed with the Framingham data set, we used his models to assess this population. And they're actually, see, there's 55% and 45%. For the people with high risk, they're getting a dramatic reduction in their risk. One of the problems they have, though, is 90% of the people have no risk. And they're doing the same thing for them. Okay? And so part of the thing is we have to stratify, or the thing is just not economically viable at all. I mean, you all knew that in advance, but.
Bill, quick question. The $2,500 per person, was that net cost, or was that the, so is that an incremental cost over what the routine care is? Because presumably you're offsetting doctor's visits, as you said, right? They're not
Right, that's what we're projecting, offsetting doctors.
So you're offsetting doctor's visits, and you may be drawing less blood, and maybe hospitalizing them less. So is that a net, what is that $2,500? Is that just the cost of the coach?
No, well, it's the cost of the assessment and everything. I mean, the blood work is $1,000 each time, the way they do it now. Right, and so that's just, but the $2,500, somebody gave them $10 million. They said, let's just make it $2,500 a person, right? And then they designed it. But now we're actually designing it to make it economically viable. Each step, how much do we need to do for what populations that actually gets the impact? Yes?
So I have trouble figuring how you spend $2,500. Doing CAT scans or something? Screening stuff? What are they kind of things?
Well, it's $1,000 of blood work, and the first year they come in twice, so it's $2,000 of blood work.
It can't be worth it. It can't need $1,000.
Well, no, we're going to show it isn't worth it, okay? But that's just what they're doing.
But that must be charges rather than costs, because,
Even that.
Right.
because what's the cost of a blood test?
Stuff that's all been looked at.
Okay, so here's the results. We basically, we had to get away from a capitated system. We went to, they get 75% of their payment is from risk reduction and 25% from capitation, okay? We use this is all based on their clinical data. This threshold here puts about 10% of the people in the high risk. So the 10% of the people get a full court press, 90% of the people get a real light interaction, okay? Basically what happens is that for the university over 25 years, they get a 7% ROI on that expenditure, and the provider organization is able to stay in business. The blue is positive, so they stay in business. We explored 700,000 combinations of these sliders. There's only 2,000 where where neither the university has a big loss or the provider goes out of business. So there's a lot of combinations that just are not viable. But let me present in a list the results. Here's what we concluded to them and gave them these recommendations. If they scale up their current prevention and wellness program, it'll yield a minus 96% ROI. In other words, you lose all your operating capital every year. This is about as bad as you can get. I mean, you can get worse, but okay. Yet they're improving dramatic improvements for people with high risks. So the clinical data for that 10% of the population is really improving in terms of probability diabetes, probability heart disease. Again, these people don't have these diseases. Okay. If we radically reorganize the program computationally, we can actually get a positive ROI. Now, interestingly, and this is probably the most fascinating result we've got, and we've been exploring it further. If instead of running the analysis through 65, the nominal retirement age, you run it through 80, the return on this investment is 30% per year. Okay. That difference between 7 and 30 is all to the benefit of CMS, but CMS pays for none of this. What CMS should do, in my humble opinion, is they should incentivize employers to take better care of their people so when they hit Medicare, they're not so disease-ridden. Right? It's just a wonderful economic argument. And the work we're doing with Bill Stead and Vanderbilt on chronic care management, and this is now after people have diabetes and heart disease, he actually has been talking with CMS that if we can, in a defensible, provable manner, show that we're saving them money by treating 40 and 50-year-olds better, will they make an investment? And they've apparently been open to the discussion.
But you're saving them money the CMS folks that have to make that decision.
Those people won't be there, right?
You're right. You're basically
That's right.
arguing John Berwick should do something before he retires back to Harvard,
Right.
which he just did.
Right. Right. Well, yeah, and this is a central problem we have. I did a big study a few years ago on how we invest in defense systems. And one of the basic conclusions we reached is some really poor decisions are made. And we had, like, the Undersecretary of Defense in the discussion. Some poor decisions are made because actually there's no one in the room that owns the future. They're just dealing with near contingencies. And so they make decisions now that save a little bit now and result in enormous costs later. It's just very analogous to healthcare.
In this instance, only 7% return on investment probably isn't enough to get your CFO to
Well,
buy into a program that's going to cost you $10 million with
well, no, it's not going to cost $10 million at all. I mean, the way we've reorganized the program, their budget dramatically goes down. Okay, because we're not doing $1,000 blood tests on people other than people. You can identify the high risk people for about $50, and then after you decide they're high risk, then you do more with them. And so that's and one of the interesting things I want to mention about using these models is the normal way that people we're working with would have thought about doing this is they would reorganize and pilot test it. Okay, because they wouldn't think of doing it computationally. Okay. What we were able to do computationally is basically get rid of an enormous number of terrible ideas and then to refine the good ideas, and now they're thinking about how do they roll it out. I mean, you do want, in the end, to do a pilot test.
You have to focus down on what had the effect, and I'm guessing that it's cholesterol and blood pressure, and maybe you are getting people to lose weight, which would be good in the model.
Well, what's having the effect is the coach.
When that's on
And they're losing weight, and they're getting exercise and stuff, yeah.
But I mean, it's $10 for the testing.
Yeah.
Top the efforts.
Yeah.
You know, I just want to say, this has been a problem in prevention for as long as I've been, able to
Mhm.
understand anything. I mean, this is the not to crack. And it even extends to, like, if you ever do, like, a health risk appraisal on a personal decision making, and you have someone who might be a 20-year-old who's obese and smoking 3 packs a day, and you give them their results of the risk appraisal, they're not going to die till way out, which actually encourages the behavior and actually enables the tobacco industry and food industry to continue to make people ill, because that has immediate financial gains, where
Right.
this has very far-reaching. I mean, that's
Yeah. Well, with this stuff, the study we did with the government, we looked at on the defense. We looked at a lot of other sectors, and there's one conclusion that overwhelmingly comes out of it, is that when the entity investing in prevention and wellness, or health and safety, other things too, when that entity investing actually sees the return, they're much more likely to do it.
But the return doesn't benefit. It's this, this economic 3-year out, it's discounted. Anything beyond 3 years has much less value.
No, we've got great examples from Johnson & Johnson, from Honda, from other companies of where they make major investments in the well-being of their employees, and the analysis just shows it's well worth it.
I would agree with that, but it hasn't changed the spending of NIH, it hasn't spent. This, I think, is the critical issue.
Right, right.
If we could solve it.
Yeah.
How do people select into this coaching program? Are they randomized in, or?
They selected a population that was representative of the whole Emory population, and then they were invited. There was no cost to them whatsoever.
Or they can refuse and just?
They could
go on
refuse.
their
The
own?
retention rate is about 90-some %.
Okay.
Yes?
Does your model assume that every year that this person is participant in Emory, say you have a 50-year-old participates for 1 year, does this model assume that you're going to continue the health coach program every year for 15 years? And if so, is there any evidence that the effects of the program will be longer lasting?
We only have evidence for 3 years, empirical evidence.
So your model
We're-
assumes that
We're
it
just
affects you
projecting
for
that.
1 year?
Right, now,
Same.
after they've been, we have you can decide how long they stay in the main program, and it's either 1, 2, or 3 years, and then they go down to a very low cost effort, where we're spending maybe $100 a year on them. But I find it very interesting. There was an article in New Yorker by Atul Gawanda a few weeks ago on coaching. I don't know if you saw that. and he has a coach he's a surgeon. Actually, it turns out my son and his son are in class together. He has a surgeon, older surgeon, who coaches him, watches him when he's operating. And he was talking about everybody needs a coach. And I really think the impact these people have who are, they're making like $20 an hour. But they're just really good at it, motivating people. But that's, let's get beyond that. Now let's talk about how do we do this, empower patients. The first issue is you can only influence them. You can't make them do anything. I suppose you can scare them. And I think there's 3 issues. And I'm going to define these 3 different terms in a second. The other thing we need to keep in mind in the complex adaptive system is the other stakeholders will react to empowerment. Okay? They'll feel a loss of control. They may object to the transparency that you know exactly how well they're performing all the time. That's what the consumer is basing their decisions on. And they could game the system. So let's talk about patients as intelligent agents in this system. By empowering, what it means to me, and I realize this may be a debate for the rest of the day and a half, is basically saying you're in charge of your health. I'm not, as a clinician. You are. Now the question, of course, is whether people will accept that. My experience has been with some older folks, like my parents, where they sort of like the idea the doctor was in charge. But I think that may be changing. Motivating is here's why it's worth for you to do it. Now there's a lot of ways we can portray this. And finally, here's how to take charge. And I think if you don't have all 3 of them, it doesn't work. But you could do it in different ways. So you're in charge. It's your life, it's your health, it's your money, it's your decision. I mean, come on, guys, right? That's how the coaches and the Emory program interact with their participants, they're not patients. Okay, is that, here's all the data, you're in charge, what do you want to do? And the person might say, well, I don't know if I should do this or that, and the person's trained enough to tell them the implications of that, et cetera. Here's why it's worth it. You'll stay healthy and more energetic for many years. One of the interesting things in the Emory data, they collect all sorts of assessments. People who walk an average of 1 hour a day are happier. I mean, these are all sorts of little side things, not just diabetes and heart disease. Your health challenges will be manageable. You'll be able to minimize pain and suffering. You'll be more productive. You'll get greater income, and you'll lead to greater enjoyment. Okay, I'm just proposing these. I'm not saying this is a litany or anything, but that's what I'm trying to define the terms. Then enabling, you need information and understanding, information and prevention and wellness, disease and treatments, consequences of treatments, understanding your role. So for example, I mentioned I spent a week in a spine surgery course, and I've had rather significant back problems, but I've avoided the spine surgery. After seeing the doctor's lectures on what they do, they asked me, well, what did you learn this week, last class? They said, what did you learn from us this week besides giving your lectures? And I said, I learned that I want to do my best to avoid completely what you're good at. Okay? To really understand the consequences of the treatments. Now, how do we motivate and enable? First of all, I think, and now with the IT, this is so much more feasible. We want to tailor the support to the individual patient's inputs. The health coach does this in the Emory program, but remember, the health coach is all cell phone and email. They see their participant once every 6 months. We want to portray the consequences for that patient, not just in general, to the extent that we can. Help them develop a plan, but it's their plan. Monitor their results. Coach to help the patients to learn and adapt. One of the things the coaches commonly run into is people just can't achieve their goals, and they get frustrated. The coach helps them to reframe their goals. Say, okay, let's break this down into steps then. You can't get there as fast as you'd like to. Let's do these simpler steps, trying to create some success. We know a lot. I know, and many other people in the room here know a lot about human-centered design. There are different processes we can go through. We need to design these systems. We need to understand 3 things. We need to understand humans' limitations of what we're asking them to do. We need to understand their abilities and asking them to do. We need to understand what affects acceptance what affects their willingness to do it. Okay, and there's a tremendous amount of literature and data on that. And then we have an enormous number of enabling technologies that I'm sure we'll be talking about for the next day and a half in terms of information access, games and simulations. We've worked a little bit on a game where you could sort of decide how you wanted to behave, and the game would portray your life in the future and how your family felt about what happened to you. Okay. Internet portals. So the work with Vanderbilt, Billstead has succeeded in getting the cost of chronic disease management down per patient for people with diabetes, hypertension, and heart failure. And the problem, of course, is by getting the cost down per patient. The way he's done it is by having them not get to the hospital, so it's a revenue hit for Vanderbilt. So he's got to figure a way to scale it up, and that's how we're helping with these models, to scale it up, because he's got to get bigger population served to use his capacities. Okay. But how had he done that? Well, one, for example, is they go to the My Health Team portal, and the people who are not in good control, they put in their blood pressure, they put in their fasting glucose and other metrics every day. And the care coordinator, who is not a clinician, checks the internet portal every day for any of them that have signs of being out of whack, and so they're prompted to it. And if they're out, the care coordinator calls them. The patient doesn't have to find the care coordinator. The care coordinator calls them and talks to them about what's happening. Did you go on a trip? Did something happen in the family? How are you feeling? Et cetera. And usually it has to be a reading that's out of whack twice, not just once. Okay? And then they decide how to manage the people coming in. A lot of people never make it to the doctor at all. As a consequence, Vanderbilt gets zero revenue for it. Okay, but they're trying to do this and scale it up. This, again, is a tremendous benefit to CMS, because half their patients are Medicare, excuse me. Yeah. CMS is the people who pay Medicare and Medicaid. Now, how are other agents going to react? And I've made up some quotes here, but these are things people have said to me. Okay? Other agents are going to feel loss of control. They're going to say many and perhaps most patients are not capable of managing their own health. That's why I went to school. It isn't just doctors, it's doctors, nurses, other people in the system. Objecting to transparency of their performance. People will say their health outcomes that are achieved are only partially affected by clinical decisions and performance. That famous chart that it's 10% what the healthcare system does, 40% your lifestyle, 30% your genetics, and 20% your environment. And then gaming the system to sustain power and position. I mean, people have invested a lot to get where they are. One of the things we spend a lot of time on is the whole question of how enterprises are transformed. Healthcare being one, but we work in a lot of other domains too. And one of the biggest problems you run into is that organizations and people have invested enormous amounts of resources and energy to get really good, assuming the current business model will continue. And now you're about to change that current business model. It's not surprising people push back. It's a big change. So I don't know how much we're going to spend the time dealing with patient empowerment and that part versus how much we're going to spend time on getting the rest of the system to accept it and support it and help it succeed. But that certainly is an issue. So back to my final chart here. I think the things we're projecting to happen are going to happen. And I guess what we're doing is setting up a research agenda so it can happen well rather than just happen. But I think once consumers get information and get educated about it and I think we don't need a retail coach. I think we probably will need a health coach because it's more complicated than buying a toaster. Although it's interesting, some people have said to me, the parallel between retail and healthcare is not fair. And I said, I know it is. There's some things that are really not a good comparison. For example, if Walmart ran the way healthcare ran, and you went in and bought a toaster, about 3 months later you'd get 12 bills for all the different pieces of the toaster. Okay? Some things you didn't even realize were in a toaster. Okay? And then you try to figure that out. Well, retail's made it a little easier for you. I think we can do a lot more to make it easier in healthcare too, and that the consumer will demand it. So, thank you. Yeah?
For retail, which it's not exactly analogous to a health coach, but it does kind of, if you wanna buy a toaster, if you wanna buy, when you said you don't really need coaches in retail, I thought, well, I kind of need a coach in retail.
Right,
Who is trying to look through everything to figure out what the best toaster is.
right. But you don't need someone to call you every week and say, how's your shopping going? Right.
Well, on budget management side, you do actually. There,
Okay.
there the parallels are strong.
Okay, yeah, no, that's a good point. That's a good point.
What'd you say?
Budget management, the parallels between that and health insurance.
Yeah,
You're talking about an order of magnitude or 2 orders of magnitude spectrum of different kinds of situations. So if I'm too heavy, my blood pressure isn't good, it's the only way to do it, what you're describing. There's lots of papers that have proven that already. You call them up and remind them, it goes better. But what do